Welcome back to the next part of gastroenterology, which will be the subject of epigastric pain. I send out these tapes to you around the world like letters from God dropped in the street. Walt Whitman says, "Why should I wish to see God better than this day? I see something of God in each hour of the 24, in each moment therein. I find letters from God dropped in the street. I leave them where they are, for I know that others will come punctually forever and ever." So that's what the tapes from Kaplan are like. They're like letters from God dropped in the street. Don't worry about it. Others will come punctually forever and ever, just like these tapes. Epigastric pain. And here on the subject of epigastric pain, we say, well, is that an apple? No, that's your abdomen, dude. That's not an apple. That's your umbilicus. Now, epigastric pain. One of the most difficult things about epigastric pain is that it's actually almost impossible to be able to tell what the precise nature of epigastric pain is without endoscopy. Epigastric pain, well, all we know about it for sure now is that it is impossible to be diagnostically precise without endoscopy. In other words, that epigastric pain could be reflux disease. That epigastric pain here, another name for that epigastric pain is dyspepsia. The epigastric pain could be ulcer disease. It could be gastritis. It could be reflux disease. It could be pancreatitis. It could occasionally be gallstone disease. It can be all of these things, and it's almost impossible to know for sure which one it is. As a matter of fact, for every 100 people who have epigastric pain, cancer is the least common thing. Pancreatic disease, gastritis. Now, I know that you think that gastritis is the most common cause of epigastric discomfort, but it's not. Gastritis most commonly presents as painless gastrointestinal bleeding. Most commonly presents as painless gastrointestinal bleeding. So therefore, epigastric pain is more common to be ulcer disease, both duodenal ulcer disease and gastric ulcer disease, but more common than that is reflux disease. Gee, what's the single most common? Pancreatitis, duodenal ulcer, gastric ulcer, gastritis. What is the single most common cause of all of those forms of epigastric discomfort? And the answer is that the single most common causes of all those forms of epigastric discomfort is in fact no identifiable etiology. Non-ulcer dyspepsia. Now, non-ulcer dyspepsia is the group name given to those things that cause epigastric discomfort in here, but you do the scope and you find nothing. You do the endoscopy and you find no disease. You do barium, you find no disease. You do the acid testing and you find no disease. It's a functional disorder. Now, if that's the single most common, accounting for 50 to 70%, depending on the age group, if it's 32-year-old doctors studying USMLE Step 2, 24-year-old medical students for studying for USMLE Step 2, it's probably 80% is non-ulcer dyspepsia. What do you mean non-ulcer? That's not a name what it's not. You can't name it what it's not. You just said the name of it is what it's not. That's like saying, what's your name? Not Bob. Or what's your name? Not Peter. What's your name? Not George. Well, what the hell is your name? You're telling me what you're not. You didn't... Yeah, well, you know, look, I don't make the news. I just report it. Therefore, that's the name of the disease. It means not this and not that. It's not this and not that. And now, when you exclude everything else, it's a functional disorder, like irritable bowel syndrome. Irritable bowel syndrome is basically abdominal pain with no identifiable etiology lower down. You scope and you scan and you CT and you do barium and you find nothing. Irritable bowel syndrome. Now, the question is, who should you scope? Who should you do endoscopy on? Who should do endoscopy? This is a very difficult question, and I could tell you that depends on your judgment. That depends on the individual case. That depends on... But I know what you want for step 2. You don't want judgment. You want it like law. Guilty, not guilty. You ready? If you're over 45 years old, scope. If you're under 45 years old and generally healthy, no need for scope. If you're under 45 years old and you have some sign of evil with your pain, I may be 41, which I am. I may be 41, but I've got pain here and dysphagia. Scope. I'm 41, but I have pain here and I have weight loss. Scope. I'm 41 and I have pain here and I have anemia and I have guaiac-positive stool and I have GI bleeding and I have weight loss and I have dysphagia and I have anemia, GI bleeding, anemia, GI bleeding, guaiac-positive stools, weight loss, dysphagia, odynophagia. That's alarming. I may be only 41. I'm balding like an 80-year-old, but I'm only 41. But I have something like weight loss and dysphagia. Not just pain, dysphagia, difficulty swallowing. Blood in my stool? Anemia? Ah! That's so alarming! Now, what is the term that we use to apply officially to things like weight loss, anemia, guaiac-positive stools, GI bleeding, dysphagia? What do we call those symptoms that are so alarming? Ba-dum-bum-bum, alarm symptoms. That's as funny as you get if you're a gastroenterologist. I'm sorry. Again, that's what they call it, and if I could get it funnier than that, I would. But alarm symptoms are things like weight loss, anemia, guaiac-positive stool, dysphagia, blood in my stool, difficulty, not just pain. Alarming symptoms, if you're 20 years old and you have one of those alarm symptoms, the time to go is, scope me. Under 45, healthy, no alarm symptoms, no alarm symptoms. And the answer is don't scope. You can give an H2 blocker, ranitidine, famotidine, nizatidine, cimetidine. Ranitidine, cimetidine, nizatidine, famotidine. Now you may be wondering how come I didn't refer to ranitidine by the brand name of, or famotidine by the brand name of, because generic names are better to learn for board tests. The second thing is, after 13 years, 14 years of board review next year, 14 years of board review, and 50,000 students, still never 1 hour of that for a drug company. Therefore, anybody who says that ranitidine is better than famotidine, is better than nizatidine, is better than cimetidine would be incorrect. They are selling something. They are all equal. It's a class effect. You try H2 blockers or one of the proton pump inhibitors. Now, the proton pump inhibitors, whether that is omeprazole, lansoprazole, esomeprazole, rabeprazole, esomeprazole, lansoprazole, pantoprazole, esomeprazole, rabeprazole. Which of these is the best one? And the answer is they are all equal. Omeprazole, lansoprazole, esomeprazole, pantoprazole, rabeprazole, and now you may be wondering why I didn't refer to omeprazole by the brand name of, and that is because anybody who says that one of these is better than the other is selling something. It is a class effect. Generic names are always good for board tests. Manufacturers' names are good if you're looking to get a piece of pizza from a drug rep. But other than that, This is a class effect of proton pump inhibitors, a class effect of H2 blockers. And therefore, we refer to things by their generic names and say by class. Well, if the class is all that matters, why are you giving us the individual names of omeprazole, esomeprazole, lansoprazole, pantoprazole? The answer is so that you know when you see the drugs in the question what exact class that they belong to. And you can recognize them. So when do I scope? When I'm older or have alarm symptoms. Ultimately, why am I scoping? I am scoping ultimately to exclude cancer. I am scoping ultimately in order to exclude cancer. I don't need endoscopy to diagnose Helicobacter pylori. I don't need endoscopy to diagnose Helicobacter pylori. I can diagnose Helicobacter pylori by serology. I can diagnose Helicobacter pylori with breath testing. I can diagnose Helicobacter pylori with stool antigen. Stool antigen? You mean inside the stool, you're looking for the stool of Helicobacter pylori? Yes, we're looking for H. pylori stool in your stool. You mean I'm looking for the poo-poo of a bug in my poo-poo? Yeah, that's kind of funny, isn't it? You're guaiacking the organism, meaning that the antigen is released from the little bodies of the Helicobacter pylori inside your stool. I can diagnose Helicobacter pylori from a biopsy. I don't need to do endoscopy to diagnose Helicobacter pylori. I am diagnosing a Helicobacter pylori by one of these things. I have to do endoscopy in order to exclude cancer. Now, since non-ulcer dyspepsia is a diagnosis of exclusion, how do I recognize the case for the other ones?